vast majority of healthcare issues are located in the elderly. This is, as an analyst, this might be surprising, but I don't like statistics. And let's just say that aging in place is really important. And if you start looking at the statistics in healthcare costs, it's an enormous portion of healthcare costs are located around the elderly and the care that they need to receive. And this takes place also in healthcare facilities, but also this focus is, okay, once you're outside of the healthcare environment, where are you going to keep that person independent and outside of a very high-cost healthcare environment as long as possible? Aging in place is specifically about once you're outside, when you're in the home or in independent, where you can have some level of independence. We're not talking about being sick in a bed. Really here, we're talking about being independent and having an independent life, a much more positive perspective than the past of many elderly care models. And then finally, there's a lot of evidence around this, and I'll go into the specifics around this, but there's a lot of different applications you can get into in different markets. And I'm an analyst. I look at markets. In the end, I look at revenues and units and pricings. But even to that effect, there are some very established markets in aging in place and some very emergent ones that are all kind of emerging and getting and kind of overlapping and working together. So as I told before, I specifically cover telehealth, and telehealth for us, as we define it in one of the more general global definitions, is healthcare at a distance. So it's not telephone-based, it's healthcare at a distance. So the purview is very, very large. It includes, here we have the three main areas that we have under telehealth is video conferencing solutions such as video telemedicine, remote monitoring solutions, and mHealth, and then other aspects of general healthcare IT. But as you can see, aging in place is right in the middle of that. It includes all of these aspects in various ways and is really in the middle because it is the core of solving a lot of healthcare issues that we have. Anyone that's been to any elderly care facility or independent living facility or even home-based solutions understand there's a lot of work to be done to improve these places. So here's kind of my overview walkthrough. The next 3 slides are interconnected, and I'm going to walk through some of the very broad and diverse applications and systems that are utilized in aging in place right now. This is not even a very future-looking thing. This is all, just to cover what we have right now is going to take all of my time, but there'll be future-looking aspects in it. So first you have the integrated systems. These are the kind of increasingly platform-based technologies like a tablet, like a desktop hub that's customized, made for a home. That kind of is the plug and interface and communication hub for all of these systems or devices. And then you have what most people think of as the different types of things, which are the applications and products. These are the actual devices that are monitoring. These are the services being provided. And then finally, you have the overall programs and protocols and such that these integrated systems and their products and applications actually fit into. So here you have the actual business models. You have the customers. They're parts of these actual existing for quite a long time programs. And so here's an actual specific listing of these. In integrated systems, you can start off with consumer phones and tablets. That's what a lot of focus on mHealth is, but actually isn't a lot of what happens in aging in place right now. More aging in place technologies are more on the bottom, where you have customized, fully customized, provided to the patient consumer technologies like phone and tablets, or you have specialized tabletop hubs or other FDA-approved specific devices created for these solutions. Then you have the applications and products, which are really the core ideas and applications that people think of with the market. You have personal emergency response systems, which we could spend an entire presentation on. They're a very significant portion of revenue and activity in the market. And then you have things like self-recording, logbooks, things that people do all the time, but digitizing that into a real format. Queries and questionnaires, medication management, activity monitoring, remote monitoring, bedside fall detection, and finally video conferencing as a video consultation tool or communication tool with elderly. And so finally in the end here, which gets a little more specific, I think, and a little more deep into what is actually going on here, you have the different types of programs that are already existing that are starting to utilize these advanced technologies to improve their outcomes. And so these are health and wellness programs for things like your self-insured employers, but for elderly specifically, you get into disease management and home care programs that have been around for quite a long time. And then you actually get into it, some sort of assisted living or independent living facilities and the types of technologies they can utilize to dramatically improve their world. And then finally, these are actually organized on a spectrum, which at the top is arrow indicates is the most independent of these types of applications, integrated systems, and products. And then you start moving down your independence level where you get to more dependent solutions where you're actually having some sort of healthcare professional involvement of some kind, because let's be honest, there is a very distinct spectrum along independence for aging independently. You're not going to have everyone be able, there is cognitive limitation, there's physical limitation to these elderly patients, and that's fine, but you have to, from a business point of view, your business models and products and applications change dramatically as you move along that spectrum. I don't have anything all the time, so I'll just pull out my phone to make sure I'm not taking too long here. Perfect. And so here's specifically that spectrum laid across on business models. The more you get on independent, the more you have self-payment type of models like PERS. PERS is paid out of pocket by patients, a very unique model around that in the U.S. and in the world. But then you go to more dependent, you involve more healthcare providers, you get more involved in healthcare-related billing, healthcare-related needs, and then therefore business models. So when you're selling into an independent care facility, it's very different than selling to the loved ones of a patient or an elderly person who's being discharged into the home from that facility. So that changes your business models and your pricing models and all these types of things dramatically as you move along the spectrum. And at the bottom, you have the different types of programs just laid on there as another point of reference. And then finally here, I wanted to end this with, this is a slide I use in most presentations. These are the top 20 telehealth markets that we identify, and we have them ranked and have different things around them. But I've included it here because 5 of those top markets are aging independently markets. And they are, and some of the bigger ones are home healthcare disease monitoring type of markets. Also PERS and medication management and activity monitoring. Activity monitoring specifically is the use of motion sensors in the home to tell where people are walking around when they get up, when they're having breakfast. And then finally, wellness programs, which is a pretty nebulous world still, but absolutely important to certain aspects of elderly care. So in this, we have 2 axes: the consumer focus, or the customer focus, which has a professional on the top, which is your, a professional type of product that needs intense training, and then you have true consumer at the bottom. And then your industry focus, which actually defines most of your business models again. When you have ICT, which, I'll use conferences. If any of you have gone to CES, which many of you probably have, that's ICT. There's for an example, you can market things in ICT before they even exist. That's the common practice. In healthcare, you go to jail if you market things before they're FDA approved. So there's some very distinct differences between these 2 industries that are constantly coming together in these types of solutions. And this is for additional information for our European team and North American team, but that's the end of my thing. I'll open up to any quick questions. We'll have time at the end for more specifics as well, but David might have some too.
Maybe just one of the burning questions. Meanwhile, there's a bunch of seats here for those sitting in the back. Feel free to come in, and thanks. Yeah, and if you're going to want to have a question, just jump up to the microphone there so we can get it recorded. Anybody going to be the first victim?
No.
Oh, we have the first victim. Thank you.
All right.
And if you could just introduce yourself, please.
Camille Roussel from National Lutheran Communities and Services. Since you work on a global scale, do you see the regulation in America more hampering innovation and our move towards mobile health and all that compared to other countries?
Yes.
So, I mean, what policy changes should we be pushing on to make sure we're still protecting patients, but not stifling, innovation and leading, being a laggard in the worldview?
So there's a lot of ways to go around that. One of the advantages of having that strict innovation is that once you go through it, you're through it, and you can go anywhere else in the world. And that's actually a strategy that people go through. They focus on the U.S. and we're going to get done the worst part of it, and we're going to get it done, and then we can go anywhere we want in the world. For example, going to Latin America or South America, if you get through the U.S., they don't even care anything around it. So there is some positives to those negatives. But on that specifically, it's just the FDA relies heavily on the industry to really guide these type of things, and they always have. And so if it's not an equivalent to an existing regulation or approval process that's already out there, for example, making a glucometer equivalent to a mobile glucometer that has information capabilities for transferring wirelessly, equivalent to an existing glucometer, that you can do. If it's something that doesn't have an equivalent and you can't figure out an innovative way to kind of put it together, those they have to make from the ground up, and those take a long time and will rely on heavy industry influence. It won't happen very quickly. But again, it's just industry is I think understood how impactful it is on the FDA, and then working hand in hand with them to get those things forward. Now, it's just I don't have any solutions around it directly. It's a long, dark tunnel. But
It's a good question, and perhaps for a future panel we should have somebody from the government here as well.
right, and I'm sure other panelists can address that too if we get to the end.
Great. All right. Thanks very much.
Right. Good morning. Can't believe it's packed. So my hope is to do this as quickly as possible to get out of the way so you can see the content of our other presenters, because they've got the really cool stuff, the actual technology stuff. I'm here to give a little bit of a color on why ARP would be at a conference such as mHealth. We get a lot of what in the world are you doing here, but also to get a little bit of background about the needs and wants of folks in this demographic, and hopefully try to convince you that aging in place goes hand in hand with caregiving, and it's hard to separate those two. So when you're considering your business models and your audience, that you take that into consideration. So just a little bit about ARP. We're not actually an insurance company. I know most of you think we are, and I know most of you dread getting our direct mail when it comes to when you're 49 and a half. But we are a nonprofit, social mission and social change organization. We were founded in 1948 as NRTA, the National Retired Teachers Association. ARP was then founded in 1957. Right now we have over 37 million members. Our publications are one of the most widely distributed in the world, coming to 22.5 million households. I work, as I mentioned, in the Thought Leadership Program. I'm going to read this slide to you. I'm kidding. But basically, what I help to do is to manage a program called Innovation of 50 Plus. We believe that it's part of our social mission to help stimulate innovation and new products and services that meets the needs and wants of people over 50. And ARP, through our group, is taking a new tact in that we're reaching out to entrepreneurs and the investment community to try to evangelize not only on the market sizing, which I'll get to in a couple seconds, but that there's a social good to be done by building new products and services that can meet people as they age and improve the quality of life for all, which is actually our mission. So there's tons of jargon in there, so I'll just get it off the screen. So why would anyone really think about the 50-plus market and consider it separately? As you can see, there's a lot of people that are aging. The baby boomers have now started to turn 65 at the rate of about 10,000 to 12,000 a day, depending on which demographer you believe. And as you look out, there's going to be a lot of people with a unique set of needs, some of which are going to be related to the deficiencies, the declines of aging, the things that happen to you. But in a lot of ways, it'll be needs and wants to help them get more quality out of their life, to be more active, to be more engaged, to be more social. Like Zach, I'm not a huge fan of statistics, so I'm just going to blow on. I think that the thing you should keep in mind is there are 100 million people over 50 right now, and it's only going to grow. And they have a lot of money. And I don't tell you that I don't want you to go and take their money, but I think it's important to consider that these folks are spending their money already. Sometimes people get pushed back and say if they're spending $2.5 trillion a year in the boomer cohort, $3.5 trillion in the 50-plus, why do I need to worry about them? Why do I need to take their needs and wants into consideration when I create new products and services? Because I guarantee if you build something that's better for them and they like, they're going to spend their money with you as opposed to your competitors. So just keep that in mind. And you can notice the only thing about this slide, although it's very pretty, is that call out that healthcare spending increases significantly when people go over 65. And that's including expenditures through Medicare and other programs. So they do consume the most health. So independent living and caregiving, this is my thesis for today. I came up with this morning, so if it falls down, please give me some slack. I've got a 6-week-old, and he didn't sleep very well last night. So here's a thesis. 9 out of 10 people over 65 want to remain in their houses for as long as possible. But they have all these issues, not issues, they have all these challenges, unique opportunities. So what can the industry do? What can anyone do to help enable this? Now, as Zach also mentioned, and I think Stephen brought up as well, even if we wanted, and I don't think anyone here, how many people here are looking forward to going into assisted living? You've been thinking about it? Something you want to do? Even if all of you did want to, even if it was like kind of the Sun City play golf paradigm, we wouldn't have enough beds for you anyway. So what we need to do is come up with solutions to keep people where they want to be and keep them healthy and engaged. this is all kind of depressing. But all right, so caregiving and aging in place. So what a lot of people don't consider when they're thinking about this market is that there's almost, you could say, two transactions. There's usually the consumer who will be wanting to stay in place, who will actually take advantage of these services, but then there's also the folks that typically are doing the research, the due diligence, if you will, and then sometimes paying for these solutions. So what we find really interesting, at least I do, is how many caregivers there are, unofficial family caregivers, and how the solutions for aging in place need to be tailored for both their needs and the individual person that's going to be aging in place. I actually hate the term aging in place. Lori Orlov in the back, who is the master of aging in place, can give you a better history of the word. But for us, it's more about maintaining independence and engagement with the activities that one would like to do. So here's some examples of what we consider to be unmet needs, or what our members and consumers are telling us they're needing out of to make their transitions more successful. And there are a ton of companies, many of which are in our pavilion, that are starting to address bits and pieces, or in some cases more than one of these sorts of things. Care coordination amongst family members, coordinating who's going to go help mom, who's keeping in track and how the scheduling. If people are long distance, who will be coming in and taking care and swapping off. Time management is very important. We're all very busy. Boomers, of course, are the sandwich generation. So perhaps for one of the first times in human history, they're worried about their 80 or 90 or 100-year-old relative while they have their boomerang kids that just got out of college and can't find a job moving into their house as well. So time management is key for them. And then sometimes there's grandchildren involved as well. I think I learned the other day that the average age of a grandparent in America is 48, which I picture everyone, a little bit older. So, of course, keeping track of what's going on in the home, where the senior or where the elder is aging. Fall detection, of course, is very important. We know that falls are trigger events that usually end up with folks in the hospital. It's sort of one of those things that starts, and a lot of times, the downward spiral. Maintaining vitals and reporting back to the care team. Medication adherence, of course, is intimately related to fall detection, because when people are off their meds, they tend to usually fall, and again, it starts that. What's key to, and is often overlooked, is the socialization element. ARP has a foundation, which is a nonprofit that issues programs. One of our core areas is focused on, well, when you say it, it sounds like we're trying to promote isolation, but instead we're trying to combat isolation and keep community. It's key for folks to be engaged and in touch with the ones that they love, but also learning and growing. And so any real comprehensive solution for aging in place has to bring that into mind. So I think I've burned through that, so we can have much more time for my colleagues here. This is where we hang out if you need to want to follow us or keep in touch with us. We're very excited to be here at mHealth, and hope you guys have a great conference.
Great. Before you go, just sit down. I think it was a great point about the socialization. Can you tell me how important it is to sort of repeat that, essentially? I think there's a lot about medical and
Sure.
mobile health, but I think your point about socialization, and there's some amazing statistics about the importance of socialization when it comes to health outcomes that I think is really worth repeating.
I don't know if I can quote said
Well,
statistics, but no, I think what often happens is, so let's take depression as a negative outcome of isolation. What depression feeds into so many other ailments, so many other issues I'm supposed to be facing this way. So it's key. And what's interesting, too, is, and I hate to use this term, it's a little bit dangerous, but a lot of these technologies are going to need to be something of a Trojan horse sort of technology. So if I were to go to my mom and say, hey, Mom, we're going to install a bunch of sensors so I can watch you all the time, make sure you're okay, she's not going to be super excited about that. But if I go to my mom and I say, hey, you're going to Skype with I'm going to show you the 6-week-old grandson on Skype, my mom's much more intrigued to get a camera, have it installed, figure out the drivers on Windows XP, and actually have that happen. And what it is once she's comfortable with that, she could then perhaps start using a technology, telecommunications, to talk to a care provider or a professional. So it's kind of lead with the honey, not the vinegar.
It's fascinating. This sort of convergence in multiple industries. Anybody question for AARP? Fantastic. You're off scot-free. Thanks a lot. All right, Alice, Intel.
All right, thank you. And wow, to see standing room only for a session on aging is really different. And it's just a tribute to mHealth for having this session. But, I think we're really beginning to see a great pickup in the interest on how mHealth and other HIT technologies can really impact the aging tsunami. At Intel, we started looking at this issue more than a dozen years ago. And as we got interested in health IT and saw that this is the last industry to adopt technology, we really focused on the demographics of aging and decided this is an area that has very little research. In fact, we've determined that Intel has invested more money in independent living research than the federal government. And it's an area that's ripe for investment in new technologies. And in fact, we've had 3 chairmen, Andy Grove, Craig Barrett, and Jane Shaw, who've really taken an active lead and propelled the company forward on looking at this issue. So I'm not going to say a lot about the demographics because I think we know what they are. But I think the key is, we're going to quadruple the number of folks over 60 in 50 years. And this is going to bring changes to everything we do, transportation, housing, the Internet of Things. It's just really going to be a different world when we get to as we move to 2050. What I wanted to also say is the governments around the world have recognized this change. And through the stimulus spending that occurred not only in the U.S. but worldwide, we saw an increase of an additional $250 billion just in looking at healthcare reform and health IT playing a role. And as Craig Barrett used to say, you really don't get change until you're faced with a dire necessity. And I think that's pretty much where we are today. So this is a picture of OHSU. It's one of the campuses that our employees in Portland, Oregon, which is the place where most of our employees live and work, we use this campus tremendously. And it is just really a fantastic teaching hospital. But we don't have the money to build more OHSUs to address the aging population. We really need to look at this as a main campus and then decentralized care. And we like to compare it to the decentralization that happened when the mainframe decentralized into the PC and changed the way we all do business. So at Intel, we look at, today I want to really talk about 4 key elements that we look at in changing the way healthcare is delivered. First, we want to look at adopting a user-centered approach. 2, we want to connect the infrastructure for community care and research. 3, and if you had a chance to hear Mark Blatt this morning with the Minister of Health from Ghana to talk about the importance of training the health care workforce, the frontline workforce, we're developing platforms to do that through the school education program. And 4thly, to act locally but collaborate globally. So in our user-centered approach, we have a large team of ethnographic researchers. These researchers have traveled the world in 20 countries and have lived with 1,000 Alzheimer's patients to figure out what they do on a daily basis and how technology could help. We've been in 250 different facilities as well. Because without really, walking the road with these folks, we really couldn't learn what they need. Developing a solution without focusing on the user is really an act of futility. Because we know that the most effective products are those that really engage the patient from day one. So what I want to do is just share 1 or 2 examples from a collaborative project that we have going on in Dublin, Ireland. We have a public-private partnership with the Government of Ireland and Trinity College with research going on in the community to figure out particularly how we can address social isolation and cognitive problems along with fall prevention. So I think Jeff mentioned the fact that social isolation is a huge issue and it's a killer. Social isolation is more detrimental to seniors' health than smoking. And yet, how often do we have a physical when that is an issue that's even discussed with our primary care physician? But it's one that we wanted to focus on at Intel. And this is a project that we called Building Bridges. The idea is, how do we connect folks in their homes through social networking, through Skyping, and really make them independent but actively engaged. So this is a phone with a computer screen, and let me get the next slide up there. And what we've done is enabled the senior to Skype much more easily than the traditional phone, as well as to do conference calls. These are really very simple technologies. They're not, the Hadoops of aging, but they work. And we developed speech bubbles when seniors are on a conference call and they can dial into a chat line, we call the tea room, any time of day. But these enablers are speech bubbles that go up when one of the seniors is talking, and then if another senior wants to speak, there's a hand that goes up. Well, you know how it is in conference calls. You have to be really aggressive to get a word in edgewise, typically, and I wish we had these hands up in my world, but we don't. But nevertheless, particularly for seniors who've never done this kind of talking, these have been enablers that have really worked to get folks to join in. In addition, we typically schedule discussions around current events, or if there's the morning news, there will be a tea room scheduled chat to discuss something of interest. So it's really easy, but it works, and it's really about building a user-centered focus. We've been doing a lot of research work with the home and community-based programs with the VA, because they have an excellent outreach program, both in terms of their telehealth as well as their in-person activities. And as you can see on the screen, just their home-based care program with nurses going out to homes as well as doctors when needed, they've seen a 24% reduction in total cost of care, 63% reduction in hospital days, and an 87% reduction in nursing home days. And yet, the programs are not very technology savvy. So we've been supplying new technology aids and are still doing the research and looking forward to seeing what an integrated technology platform will mean to the VA. In the meantime, a separate division, and maybe you're familiar with the Veterans Administration telehealth program, they're now serving over 60,000 veterans by managing their chronic disease problems through telehealth. And what they have seen is a 25% reduction in the number of bed days and a 20% reduction in readmissions, which taken on a scale nationally could really make a huge difference in U.S. healthcare costs. One more thing I wanted to say about living independently. The demographics have really changed. In 1950, only 10% of all Americans over 65 lived alone. Today, a third of older Americans live alone, a figure that rises to 40% for those 85 and older. So keeping these folks actively engaged in social networking, social contact, can make a big difference. Interventions. I was so glad to hear Jeff talk about the fact that you need a pull to get seniors involved in this kind of activity. And we think that the Building Bridges is a great program. Secondly, we have been working with a program in the UK called Finer Day. And in the UK, there's a real effort, movement afoot to have seniors build their life stories online and on paper, so that it's not only a healthcare story, it's about engaging them in really chronicling their lives, which will lead to healthcare remedies and solutions. And Finer Day has a great portal. It offers video, but it starts with getting the grandchild's picture up there and starting to do video chat. It's a launch in order to get seniors more comfortable with the technology so they can use it for higher degree health care as time goes on. And next, I just wanted to say a few words about what Intel is doing in China with age-friendly cities. And I think the movement in the U.S. is very active. New York, Portland are two of the leading cities that have adopted new technologies and really looking at how to make their cities more comfortable. But in China, we have an MOU with the Ministry of Civil Affairs to develop a blueprint that will enable all kinds of different activities for seniors to take place through a broadband connection. We're just starting to do this research, but it has been really eye-opening for us because the Chinese have a huge issue at this point with their one-child policy. They realize that the tradition of caring for their parents is really being disrupted by the movement of folks from the rural areas to the cities. So these demographics working hand in hand are creating a huge issue for the Chinese, and they're turning to technology to solve it. The building blocks, of course, for building a national system, starting with a few cities in provinces, require management, security, communications, and then connecting, the Internet of Things and ensuring that we have transportation, food services, education for seniors on a secure platform is really key to the success. So what the Chinese government has done in their last 5-year plan is set goals for the country. The first is that 90% of seniors will live independently in their homes. 7% will be cared for through home and community-based organizations, and 3% will be in institutions. So when you have that goal out there, you start to work towards it. And as I said, technology is going to play a major role. So as we develop the blueprints, as we learn from this experience, we're very anxious to share these learnings, and hopefully by the end of next year, we will be able to provide that information. And next, the fourth point that I wanted to share with you is act locally, collaborate globally. I think we're all aware of the fact that we have a lot of disjointed programs going on in the U.S. and around the world on mHealth. And Secretary Clinton, in a speech this year, said that, it's almost a cliche to say that we have too many one-off programs. So from Intel's perspective, one of the ways to address this issue is to build standards. Standards both in the technology, that we're all working off a similar platform, that we have identified the standards for mHealth, and additionally standards for programs that we are developing and partnering with others so that we're learning from our mistakes, we're connecting the dots, and that we're accelerating the adoption of health IT for this growing population of seniors. Here's just one example that standards really enabled for quick response. In Japan, when the tsunami hit, we had a group of companies that were really quick to answer the problems. And all of these companies were part of the Continua Health Alliance. I don't know if you've heard of this group, but it's one that Intel was instrumental in forming. We have about 200 companies now, and we have adopted existing standards that will provide personal connection for seniors and independent living and chronic disease and wellness. So 7 companies that are Continua members, Continua certified products came together and within 2 weeks had a solution for remote patient monitoring for these patients to be able to connect to their physicians. Without the standards in place, this could have taken months. But it's a real example of how standards bring products to market quickly and at a much reduced price. So we like to talk about this one in detail. A second program that we've been working with is in Chinese Taipei. And the Taipei government realized that there was a huge problem in chronic heart disease, and systolic blood pressure was way above the thresholds they wanted to see. So they did a comprehensive approach impacting over 600,000 patients through a telecare program where stations were introduced in homes, in community-based facilities, at the workplace, and there was the fourth one, what am I forgetting? A fourth area. So they were able to cover these 600,000 patients. 7,000 of these patients are in a plan of care for reporting their systolic blood pressure and other biometrics. And after 4 years running this program, they've seen a 5% drop, which is significant for the high-risk community. So it's one more way when you look at a problem holistically that you can really see impact. So I just wanted to start the conclusion today by talking about some of the audacious goals that we're seeing worldwide. The triple aim that's been part of the Affordable Care implementation, China's 90% in the home, the Million Hearts campaigns for saving 1 million lives by 2015, that's here in the U.S. The EU and APEC countries have both adopted goals to increase active and independent living by 2 years, by I think 2018 and 2020. And then in the UK, because of the success of remote patient monitoring and several pilots there, they have a plan, although unfunded at this point, but the goal is to monitor 3 million patients. But in order to do this, let me just mention finally several interventions that really need to happen. Once again, we have to have standards and interoperability to provide a complete care plan, particularly for seniors with chronic disease. It's not going to happen until we're really able to see the complete picture of the patient, not only the clinical but the social data as well. Secondly, aligning patients with care goals. I just found the statistic the other day, and that we have a huge right push in the U.S. to reduce hospital readmissions, but the pressures on the hospitals to fill those beds are working in direct contrast to the kinds of penalties they're going to face if they have a higher than average readmissions policy. I'm sure you know that October of this year, this program was put into place so that hospitals lose 1% of their Medicare funding if they're above this readmissions threshold. But these are two pressures really working together that really don't quite make sense. And are there incentives for hospitals to fill those beds or to get the complete Medicare reimbursement? That's sort of a C-suite financial CFO decision to make. Sometimes it may, we don't know whether the care or the finances, all of that has to be considered. Unleash the data. We have CMS data today, and through the Affordable Care Act, there is more access to that data in terms of the cost of procedures. The quality does not coincide with that data, but at least we're getting some costs. But this is essential, and particularly in caring for the senior population. This statistic just talks about in California, you can get an appendectomy for $184,000 or less than $2,000. Same operation. Until we start really addressing these inconsistencies, we're not going to be able to have the funding available because there are only so many finite dollars out there to care for our seniors. We need to demand integrated privacy and security through any kind of mobile or stationary device that's being used for health care. And finally, that really points to one of the questions that was asked about regulatory relief. We need to find those solutions that will accelerate adoption of mHealth, as well as provide incentives and reimbursement for the kind of programs that we have today. So, thank you for your attention. We have lots of opportunities here to really move great technologies for global aging, and it's just great to see so much interest. Thank you.
go to the microphone? Alice, you've got one. We'll just time for one, and then we're going to move on to the final.
Yeah, I just have a clarification question. The program that you were talking about in China, which had 6,000 people,
The Taipei.
600,000, sorry, involved. Who were the organizers, the sponsors of that?
It was the Taipei government. It was run by the Minister of Health there, and then, it involved our corporation advised on the technology as well as other not NGOs.
So Intel was a collaborator. if you
Yes.
will, in the project. Okay, thank you.
Thanks so much. Just have to, what Alice and Intel have been doing in terms of ethnographic research and global scope at Intel is really fantastic, and I commend them for it. David, over to you. Big finish, looking forward to it.
Thank you, Stephen, and thank you all for being here. I join my colleagues in saying this is wonderful to have such a large audience. Having worked in this field for more years than I like to remember, but now more recently with the technology emphasis, it is a very exciting time to see the developments that are going on in aging care and the ability for older adults to start using technologies, particularly mobile technologies. I'm going to take, for this session, take it down to a much more micro level related to programs that we have conducted at the Center for Technology and Aging that we've either supported or been investigating, because we've taken an orientation of, particularly with, as Alice has just said, some of the major factors that are moving into this, affecting this space around the Affordable Care Act and the need to approach the triple aims and the pressures that are on the healthcare system, but really how it drills down to the impact on older adults. How the programs that we've looked at have actually been assessing and changing how healthcare can be delivered and improve the quality of care and reduce costs at the same time. To start with, though, I'd just like to back up and give you a little background about the center. We have been in existence for 4 years, but we have built on a long tradition of aging services and look now at how we can see the adoption of technology, not just mobile technology, but multiple technologies in this space, how they can be diffused, taken to scale. So not working with basically programs that are in a startup phase, but more of developed programs, looking at how we can diffuse them throughout the healthcare system. We're a national resource for information in this space and have worked in these projects with over 100 healthcare organizations around the country, ranging from community clinics to large hospitals and health systems. We conduct both projects with individuals, support others, and provide consulting services to organizations moving into this area. The way we have conducted our work over the last few years has been through focusing on high priority areas in this healthcare environment where we did see the potential and already the existence for the last 10, in some cases even 15 years of how technology is moving into this, into really improving patient care delivery mechanisms. We've conducted a series of grant programs focused around these 4 areas, starting with medication monitoring and adherence, working with organizations that have looked at ways to improve the ability for older adults to improve the way they've been using their medications, as well as how professionals can work with them to get their medications in a more timely fashion. Most of our work has, in the last year and a half, 2 years, is focused around remote patient monitoring because of the quick and large advances in seeing the impact. As Alice had mentioned, the VA program is the most extensive program in the country using remote patient monitoring built around a care management program, and it's being extremely effective, as she's already related. But we've also been looking now at technologies that move organizations into the care transition process, and more this last year and a half focusing on mobile technologies directly, which is what I'll speak to today. I'd like to give you some examples of how those different programs that we've operated in work, and then we'll follow up with some of the specifics in terms of some of the findings. But I just want to reinforce that in this area around chronic disease management, particularly around complex chronics, which is now driving a huge percentage of our healthcare costs, and it's really only 5% of older adults that are in that situation, but they're taking up the majority of healthcare costs in the country, that we're looking at the ways that we can deal with individuals who, per what Zach and Jeff were saying earlier, are more on the continuum of, with a very heterogeneous older adult population, are on the more advanced area in terms of chronic disease, severity of illness, as opposed to the wellness side of the equation, all of which are very important, but we've decided to focus on this specific area. So I'll take you first through just the 6 of the programs that we've been working with, just to give a sample of what that is, and then I'll drill down into some of the results of a few of those, and at the end give you some takeaways that we've had in terms of working in this space. So first, these organizations have ranged from working in the mHealth space, gone from continuing care retirement centers through different types of hospitals and health systems, and I'll give you each example. Front Porch Center, which is part of the larger Front Porch system of continuing care retirement center that provides care to thousands of older adults in the Los Angeles area, had been in the position of needing to find ways to reach out to their residents in multiple facilities. They turned to a cell phone texting system and have now seen, as I'll speak to a little later, a significant improvement in how organizations, how their older adults can use the types of medication programs that they need. Sharp Healthcare, one of the an ACO, Accountable Care Organization, which has been a leader not only in California but elsewhere around the country in terms of how to improve and manage large populations, has turned to mHealth solutions now, building off of hardwired programs, other types of technology, but now using remote patient monitoring in an mHealth solution to deal with COPD as well as congestive heart failure. Third program is that we've worked with is seeing how healthcare can be delivered across an entire county, has been with Cal Optima in Orange County, California, where they have determined that this type of technology can help them address the needs for a large population they're responsible for managing throughout the county, and have turned to solution, in their case, using a cardiocom program with the mobile aspect to it, and have had very significant improvements in reducing CHF readmissions. And Family Services Agency of San Francisco, a regional social service agency, has taken a whole different approach in terms of using mobile-based programs to do assessment. They've used tablet platform and looking at how to use this type of technology to assess individuals with mental health issues and other social problems in terms of their interaction within the community. And the last two, which I'm going to spend some time on because they've used the same technology, has been Health Insight, based in Utah, which is one of the Office of National Coordinators beacon communities, looking at text message-based program for improving diabetes management, as has the Family Health Center in San Diego, a program that we actually tested this program, the text-based program, on how it can deliver improvements in diabetes management and behavior change. I'd like to speak to the two programs first in Care for Life because they have been a very successful demonstration of how we work within programs that have populations at risk, particularly seniors that are frail, vulnerable, and in high-risk settings in terms of community clinics. Particularly in Family Health Center of San Diego, a Spanish-speaking monolingual program, we've seen quite a significant improvement in the way they've been able to manage their diabetes patients. Both programs have used Care for Life, supported by Voxiva, in terms of a text managing program. They have been developed using a very common set of guidelines that are used for diabetes management around the country. Used a two-way text messaging program, as well as supported by a portal that is able to be used by patients and the professionals that are working with them. The program itself, it provides a number of different reminders in terms of glucose monitoring, as well as ability to track medication usage, getting reminders, and getting specific messages for what an individual should be doing on a regular basis. What's been very exciting to see is the receptivity of individuals who are using the program. I know that there are a number of folks here in the audience, not only people who are involved in these programs, but also others working on diabetes management, to see just how effective the individual messages can be in terms of changing behavior. What we'd also like to suggest is that there's much more room for looking at the way you can interact with professionals in this area, and challenges for, in this case, using a web portal for how the older adults can actually use the specific types of findings or information on a regular basis. But what's we've seen in the specific program and findings in Family Health Center in San Diego, as well as now at Health Insight, is the improvement in glucose levels in terms of their HbA1cs being reduced. Here's some results from our colleagues at Health Insight in terms of just showing how individual patients can monitor and get their readings and be able to adjust what their, in terms of glucose levels, what they should be doing. And in particular, that we found in Family Health Center findings to date that we've seen an actual decrease of nearly 1 point in the HbA1c readings for the individuals who've been using this program over 3 months and then 6 months. A few quick takeaways from the Care for Life programs that we've seen to share with you really are that you have to focus on patient activation, patient engagement. That is just a tremendous issue in terms of reaching out and getting individuals to use the mobile platform. It's the underlying issue around success in this area, but also in terms of getting provider support and engagement in this area. We've seen that there's a tremendous need to make sure that it isn't too impactful, changes the way that they do provide their care delivery process, and that it has, if anything, they see the benefit and potential additional savings, cost savings in the work that they do. In both projects, we still see a significant challenge in terms of scaling. The issue is whether it's in single community clinics or multiple community clinics, it's still very difficult to get the solution taken up by a large number of individuals in a very short order. So those will be, as we look at these types of programs, and whether it be Care for Life or other technology-based delivery programs in this area, these are the key issues that we're going to be looking at, not only interoperability and the common ways that the programs speak to each other, but also really how we can work with organizations to scale them to a critical level. In terms of the SHARP healthcare program, which focused on COPD, congestive, basically looking at the way we've been dealing with issues around their ability to manage this population, we've seen that there are a number of ways that they have been using non-technological based solutions, but that when they move to a mobile health-based device, and actually measuring pulse oximetry and looking at a care managed-based approach, we've seen some significant benefits to the population, as well as to the providers that have worked on it. The goal of the program was to reduce primarily hospital readmissions, and they have already shown significant improvements for their population from 22% to 15%, saving them on average of $9,000 per person, which is a significant amount of resources for the organization. They are now going to scale this and take it to throughout several of their hospitals in the San Diego area. A few of the takeaways that we had from the program were that we've learned in all of these programs that it takes a significant amount of time to really do the upfront work. You have to look carefully at the different issues around patient recruitment. You have to look at issues around the types of personnel and the training that needs to go into their work to move into this space. Also, that you need to look at the way programs identify the individual patients, that you have to have a very specific set of targeted group of patients to have the greatest impact. Because they did have so many COPD patients, they had to look carefully at those that would best be managed in this situation, which they were quite successful in creating that algorithm over time. And finally, that this type of work can really turn around the way patients interact with the healthcare system and their providers. They had an increase of 50% or greater in terms of satisfaction for all of their patients in this area. And finally, some specifics on Front Porch. Using the CareSpeak communications program in terms of text-based messaging reminder system for medication adherence, they were able to look at how different alerts would improve the ability of their residents in this space to use really stay on top of their medications and keep individuals living and aging in place in senior residence, as opposed to having ED visits or being admitted into a hospital for a longer period of time. It was using a large number of education as well as reminder systems, and their preliminary data have been very positive, that they have seen a very high increase. The data are still being assembled, but it looks like they've exceeded, again, 60% in terms of really closer monitoring in terms of their medication issues. What they have taken away from this is that you must spend a significant amount of time working with the patients or older adults individually, and that if they can empower and activate the older adults in different environments, that's where they're getting the greatest response and have to put most of their energy. In terms of way that they've looked in advance at taking this to scale across a number of other settings, they've been very concerned about how they developed specific training components. And that will be what they're going to be focusing on as they expand this to additional settings. Two of the things that we developed throughout this initiative and have taken away from it now are been looking at the importance of the way organizations can look at the cost effectiveness of their different type of technology. And we've worked with Center for Connected Health at Partners Healthcare to develop a return on investment model, an interactive model which is going online in the first of the year. And it's basically allows organizations to look at look at their technologies both in advance or after they've had some experience to take information to the C-suite in terms of what it's providing in terms of long-term benefits. We've used this with 5 organizations, seeing a return on investment ranging from 1 to 22 for an IVR type of program, And this has basically allowed the organizations, the staff that have put these programs in place to carry the message forward and get support for doing replication across the organization in a number of ways. The other program that we've developed is the Adopt Toolkit, which is a series of measures and tools and training programs and marketing materials that have been used by the different programs that we've worked with, assembled so that other organizations don't have to repeat the same planning, training, implementation processes. We've built that around each of the technology areas that we've been working in: remote monitoring, medication adherence, the care transitions, and now mobile technology, to, again, help organizations jumpstart their efforts in this area. I'd like to finish by just mentioning some of our broader takeaways from working with these different organizations over the last few years. And the simplest one is that it's not just the technology, whether it's mHealth or other technologies. It's really the issues around how it is deployed, how it is adopted, how it is actually implemented in an organization, and the process that organizations put in place to effectively scale their programs. The key issue that we have found, obviously, is leadership. That if you don't have a champion within an organization, you are going to have a much more difficult time getting the program not only implemented but continued, but also looking at the issues around change management. Many organizations don't spend nearly enough time looking at the care processes, the training processes that providers are currently using, and that generally have to change as different technologies are put into place. And we see nothing different with the mHealth projects that we've had than we did with a number of the other technology programs. Staff buy-in and patient buy-in are critical, and we've seen some excellent examples that we put in the toolkit of methods for the organizations to both train their different providers, as from physicians to frontline workers, in how to work in this area. That really is central to getting the program started, but also ways that you can then train patients or provide education to patients or older adults to pick up the technology and run with it. An additional area is central on this is the patient selection and recruitment process. It's been a challenge for many of the organizations as they've started these programs. How to identify who the most effective individuals will be for using the technology. And what we've seen now is not only working on how you select those individuals, but how you also change the workflow processes, how you deploy the technology and put that into place, and finally, how you create an entire communication and marketing program around how you get this information out to individuals. So with that, this is a way you can reach us or get further information up on our website about each of the programs that we've worked on. And I want to thank you all again for attending, and I look forward to comments, and as the whole panel does, look forward to interacting with you now in this important area. Thank you.